He is the founder and director of the Samaritan ALS Clinic. He is co-director of the Neurophysiology Department at Good Samaritan Hospital and a clinical assistant professor at the University of Arizona in neurology. He also conducts extensive research in disease of the nerve and muscle and continues to publish his findings in numerous peer-reviewed journals. Dr. Levine is also an advisory board member for NAF, and much like many of our other speakers today, he continues his research, so you know that there is hope and light at the end of the tunnel. So, thank you.
I always feel bad when people clap for me before I do anything. Puts a lot of pressure on me. Anyway, I did this talk a couple of years ago, I think, for this group, so hopefully some of you are new at least. But the idea behind the talk, and as Dominic and I have talked a bit, is that I think when we think about neuropathy, we think about burning and pain in our toes and feet, and we don't really necessarily think about the fact that neuropathy really affects the whole body. And so not only is it damaging the nerves throughout the whole body, but the nerves are important in a lot of different functions. And so what I try to do is just kind of briefly go over with you sort of how we think about neuropathy and the different ways in which neuropathy can affect your entire body, not just necessarily your feet. So you're familiar with this and you've heard a lot about this, but when we think about the nervous system, we break the nervous system into two parts. There's the central nervous system, which is your brain and your spinal cord, and then there's your peripheral nervous system, which are the nerves that run from your spinal cord out to your limbs and back from your limbs to your spinal cord. In neurology, when we see a patient that has a problem, the first thing we have to do is to try to what's called localize the problem. So we have to figure out what part of the nervous system is broken. And so at first we have to say, is it the central nervous system or is it the peripheral nervous system? So numb feet could certainly be peripheral nerves, but it could be your spinal cord, it could be a number of different things. And then within the peripheral nervous system, there's actually really three components to that. So there's a sensory part, which is what's mainly affected in neuropathies, which causes loss of feeling or anesthesia, and then abnormal feelings or dysesthesias, which causes pain. Then there's the motor part, which lets you move, and so if those nerves get damaged, you develop weakness. And then we'll talk a little bit more, but there's also an autonomic nervous system, and the autonomic nervous system controls a lot of the automatic functions of our body, so our heart rate, our blood pressure, our temperature regulation, our sweating, our digestion. All of those things have nerves that send signals that tell the heart to beat and the blood vessels to constrict and the gut to move food through. So all that's controlled by the autonomic nervous system. So again, most people are familiar with neuropathic symptoms. What brings the vast majority of patients to see a doctor is either a loss of feeling, so people notice that they just don't feel their feet or their toes as much, or they have pain, and the pain can be described a bunch of different ways. That's the involvement of those sensory nerves. If it starts to involve the motor nerves, then people have weakness. Most neuropathies, again, not all, but the vast majority of neuropathies affect nerves in what we call a length-dependent fashion, which means that the longest nerves are the ones that get affected first. And so I always tell people, nerves really are the most complicated cell we have in our body. So if you think about every other cell in our body, it's microscopic in all three dimensions, so length, width, and height. They're very, very small. The same cell that starts in your spinal cord goes all the way down to your big toe. So that's a 3-foot cell. There's no other organ system that has a 3-foot cell. So keeping a cell alive for 70, 80, 90 years that's 3 feet long turns out to be very, very complicated. And so as people get older, the incidence of these neuropathies go up. And then often it kind of can present as balance difficulties. So if your feet don't feel the ground well, then when you walk, you can't send signals from your feet to your brain to tell you where your feet are, and then you don't know where to put your feet next. And that becomes very unsettling and causes balance difficulties, which are very common. That's probably actually, if you think about it, of all the things that maybe we as neurologists do, probably the most important actually is preventing falls in people with neuropathies. Because yes, you heard the last talk about amputations, and people can die from that, and that's terrible, but in terms of the overall numbers of patients, the likelihood of falling, breaking a hip, hitting your head, really injuring yourself from these neuropathies is very high. And so we pay a lot of attention to the balance problems. So we have a lot of different medications to treat these neuropathic symptoms. The thing to keep in mind about the neuropathic symptoms, as I said, is there's really two types, and a lot of patients get confused by this. So they'll come in and they'll say, this makes no sense, but my feet are numb and they hurt. And so it doesn't really make sense, because if they're numb, they should be numb, and if they're hurt, they shouldn't be numb, right? But in fact, what's going on is that you've got really two sets of nerves. You've got one set of nerves that are dead, and that's numb, because they're sending no signals. You've got another set of nerves that are sick, and those sick nerves send off abnormal signals. So you're sitting in bed, and all of a sudden it feels like somebody put a pin in your toe. Well, nobody put a pin in your toe, so why does it feel that way, right? It feels that way because that nerve fired incorrectly. So for the numbness or the loss of feeling, we really have nothing. Okay? So there is no treatment for the loss of feeling other than trying to do something to regrow the nerves, which doesn't happen very often. We have a lot of medications to decrease the abnormal signals that nerves send and to try to quiet those signals down. So probably one of the biggest groups are actually the anti-seizure medicines. So seizures occur when there's too much electrical activity in the brain. We use medications to quiet that electrical activity down. We as neuromuscular doctors stole those medicines. We use them to quiet down the nerves in your feet. And they work pretty well. So gabapentin, Lyrica are probably the two most widely used, but really any of the seizure medicines can be used in patients for this kind of problem. Antidepressants like Cymbalta have the indication. Older antidepressants like the tricyclics are used. Those are really the two main classes, the anti-seizure medicines and the antidepressants. If those fail, or if there's enough pain despite those, then we usually just have to use pain medications, which typically are narcotics. We talk a lot about using nutritional supplements. There's a little bit of data for some nutritional supplements, but not great data. It's certainly something that lots of people take with the hope that you provide the nerves the kind of nutrients they need to try to regrow or to try to get healthy. I'm a fan of them, but we just don't have overwhelming data that they actually do a lot. There's some data using electrical and magnetic stimulation, infrared light therapy, acupuncture, a host of different things that people try. I've had patients try all of them, and some patients come back and say that they work. Some patients come back and say that they don't work. The hard part for us as doctors is I can't predict whether it's going to work for you or not. But the nice thing about those, certainly the last four group there, is it's not really going to hurt you. And so from my standpoint, if it doesn't cost too much and it's not going to hurt you, it might be worth a try if the pain is bad enough. Again, you just heard a whole talk about this. My main take-home message is if I'm seeing sort of a stable neuropathy patient, they should see me once a year and they should see a podiatrist once a year. So you have to take care of your feet for all the reasons that you just heard about in the last talk. So another important symptom is actually leg symptoms, so not just toes and feet symptoms. And one of the most important questions, as I said in the beginning, there's a lot of things that can cause numb, painful feet. Not all of those are neuropathy. Probably one of the most helpful questions in distinguishing those is when your symptoms are worse. So in peripheral neuropathy, the symptoms are almost always worse when there's no external sensory stimuli. So that means when you're sitting down or laying down to go to bed, and it's almost always worse at night. Other things cause leg pain, like a pinched nerve in your back will cause leg pain, right? It'll radiate down your leg. That's almost always worse when you're walking. If you've got vascular disease and you don't have enough blood supply to your leg, that can cause pain, always worse when you're walking. If you've got a foot problem like plantar fasciitis or tarsal tunnel or neuroma, that's worse when you're walking. So one of the really helpful distinguishing features is neuropathy symptoms are really worse at rest, and almost everything else that causes foot pain is really worse when you're walking. Another very common associated symptom with peripheral neuropathy is restless leg symptoms. So it's probably about 30 or 40% of people with neuropathy have restless legs. And it often is kind of mistaken one for another. So it is kind of an uncomfortable feeling. And again, what do people with restless legs do? Well, they get up and they walk around, and it gets better. So with neuropathy, if you get up and walk around, it gets better. So they sound very similar. There's usually kind of an inner drive to move with restless leg syndromes. And very frequently, people often have limb movements at night. So their legs will jerk and you kick your spouse or whatever. But that's very treatable. Different drugs, for the most part, than we use to treat neuropathy. But if you've got neuropathy and you just find it really uncomfortable to sit and watch the TV at night for a couple of hours and you're finding yourself standing up and walking around a lot, that may be restless legs. And again, there are very good treatments. You could try it. You pretty much know quickly and kind of move on. The treatment for those actually, for reasons we don't understand, turned out to be the Parkinson's medications. So again, it wouldn't be something that we typically would prescribe for neuropathy unless we thought you had restless legs. Sexual symptoms, people don't talk about this a lot, but neuropathy again affects our quality of life in a lot of different ways. Sexual symptoms are a big problem in people with peripheral neuropathy. So number one, you can damage the nerves that control sexual function, so performance can become a problem. Males have difficulty with erection or climax. You lose sensation, so it's just not as pleasurable as before. Libido tends not to be affected, so your sexual drive tends not to be affected, except all the drugs we give you for neuropathy will decrease your libido. And these symptoms do respond to the typical kind of drugs for erectile dysfunction for men, and they're actually being studied in a lot of cases in women as well. So it's something, again, that we can treat. It's worth talking to your doctor about and not just saying, well, I'm just older, I've got neuropathy, there's nothing I can do. Bladder symptoms, again, so bladder involvement is really part of that autonomic nervous system, so it's not really a very common problem associated with neuropathy. I probably have more patients that come in and say, I've got bladder symptoms, and when you really question them, what they have is kind of the typical urgency, or you're getting up frequently during the night, and it's just the fact that that's what happens as we all get older. And that can simply be treated. So again, neuropathy can affect lots of things, and it's important to talk to your doctor about the symptoms that you're having, but not everything that you have is going to be neuropathy. So urinary symptoms, I think, generally kind of fall outside of kind of particular neuropathy type symptoms. You'll see prostate disease in men, you see just the typical kind of muscle weakness in women, and there's very good testing to try to take a look at that, and you can figure out whether you have what's called a neurogenic bladder, in which case the nerves to your bladder just aren't sending the signals and you can't contract your bladder, or whether you have the typical kind of other symptoms that just come from kind of overflow and weakness as we get older. Again, there are good medications, oral medications that usually treat this. So if you've got kind of a hyperactive bladder, then we just kind of relax the bladder muscles, and we use a class of drugs called anticholinergics, which are very easy to take and well tolerated. If you've got a bladder that really is neurogenic, the nerves just are not sending signals to contract the bladder, the only real treatment for that is to catheterize yourself. So that's not quite as much fun. GI symptoms are actually a big part of neuropathy, again, primarily involving that autonomic nervous system. And so we see lots of patients that come in and say, oh, I've been diagnosed with irritable bowel syndrome for 20 years, and really the problem is they just don't have the movement. The nerves aren't sending the right signals to their gut to be able to get the food to move through. So you can have that happen in the stomach, which is what we call gastric stasis. That tends to cause kind of nausea and pain after you eat. So you eat, you got a big bolus of food in your stomach, it can't get the food moving out, and so you feel bad. In severe cases, you have vomiting and weight loss. People that have had diabetes, particularly poorly controlled diabetes for decades, this can be an enormous problem for those patients, and it's very difficult to treat, unfortunately. We try smaller, more frequent meals. There are a few drugs that we use to kind of help move the food through, but they actually have lots of side effects and don't really work all that great. Lower intestinal problems, meaning again like bowel incontinence or severe constipation, usually less of a problem, again, except in some rare isolated instances. So it tends to be more kind of upper GI than lower GI. The cardiac symptoms are a big one, and I've had a big interest in this over the last 5 years or so. I think, again, we probably underestimate how often this happens. So number one, you've got people that have pain, they're taking a lot of pain drugs, and so they complain of being fatigued, or they complain of being lightheaded or dizzy, and it kind of gets blamed on the drugs that they're taking. And in some cases, that's probably true. In other cases, that autonomic nervous system may simply not be telling the heart and the blood vessels how to control your heart rate or your blood pressure very well. And so there's a number of really interesting neuropathy syndromes that, again, involve the autonomic nervous system, where these kinds of, sort of standing up and being lightheaded, in severe cases really even passing out, can be a big part of the symptomatology. This can be evaluated. So we do what's called autonomic testing. And when we do autonomic testing, what we look for is how well your heart rate can adjust. So if you think about it, when you go from sitting to standing, very quickly you have to raise your blood pressure because you've got a lot more gravity now to pump the blood against. And that has to happen almost instantaneously, or you're going to get lightheaded when you stand up. Again, if it's worse, then the longer you stand, eventually you won't be able to send enough blood to your brain, and then you're going to pass out and fall down. We know that when patients have autonomic dysfunction, particularly in diabetes, their 10-year mortality is vastly higher than diabetics that don't have autonomic neuropathy. So this is a big risk factor, basically, of kind of widespread damage to other organs. And so it is important to kind of have this evaluated. So we do tilt table tests. We look at the way people sweat. We look at the way their heart rate changes with certain maneuvers. And there are a number of ways to try to treat this. So one of the difficult parts with this, again, is that there's so much emphasis placed on keeping your blood pressure low. But in patients that have this problem, we actually need to keep their blood pressure up. So it's the one time you'll have your doctor say you need to eat a lot of salt, drink a lot of caffeine, do all the things we say you're not supposed to do. And we take people off of blood pressure medicines, and in severe cases, we actually put people on medicines to raise their blood pressure. And it ends up sort of a fight between the neurologist and the cardiologist. They keep trying to lower blood pressure, and patients pass out, and we keep saying stop that and take them off their medicines. But this isn't a very important thing really to pay attention to, because again, it is a predictor that if we don't treat it, that there is some damage that's occurring to the heart. Swallowing problems can occur, again, not very commonly in neuropathies, but swallowing is probably the most complicated neurologic process that we have. So if you think about it, when you chew and eat, you have to very quickly be able to sense the food as it moves all the way from your mouth back of your throat. You have to control different sets of muscles. You have to close off your airway. That all has to be integrated, usually while we're like talking and laughing at the same time. So that's very complicated, and anything that damages these nerves can lead to dysphagia. And so it's important because if you start to develop dysphagia, then your risk for starting to lose weight, your risk for developing pneumonia goes way up. And those can be, life-threatening things in severe cases. So if there are swallowing problems, it does need to be evaluated, either by a GI doctor or in most cases actually by a speech pathologist who can figure out what the problem is. And in many cases, it may not be related to the neuropathy. There are lots of other things that can cause dysphagia, but it does need to be taken kind of seriously. So if you look at causes of dysphagia, you can see neuromuscular diseases way down the list, most of them kind of either due to stroke or brain injury or some kind of surgery to the head and neck that disrupts the way that those muscles function. Another kind of important thing I think that's somewhat appreciated are just sort of the emotional side effects that come from having neuropathy. There's a lot of depression and anxiety that occurs because you're dealing with pain. It's also sort of a different kind of pain because it's not sort of there all the time. It comes and goes, and it definitely is worse if you don't sleep. It's worse if you're stressed. So there's a lot of variability to it, and it's kind of unpredictable, and that tends to promote even more anxiety. So if you look at people that have just sort of chronic cancer pain, for example, there's actually less anxiety than there is from neuropathic pain. And neuropathic pain seems to have kind of a different feature to it. It's just a little more aggravating to people. It's just much more bothersome than other types of pain. So again, we try to medicate that as best we can because that's what we do as doctors, is we throw drugs at people. But probably more, I would say equally as important is learning to cope with it. So there's a point at which you get evaluated for your neuropathy. We do everything we can to figure out if we can reverse the neuropathy. The bad news is 50-60% of the time we probably can't reverse the neuropathy, and therefore you're going to be left dealing with these symptoms. And so you have to learn how to cope with that. And so there's a really great thing called cognitive behavioral therapy, which is done by sort of neuropsychologists, and it really is sort of designed, it's kind of a biofeedback sort of tool to get you to kind of cope with what you're dealing with. And it's very, very helpful in a lot of different chronic pain conditions. And then there's good data that exercise can help with the pain of neuropathy, particularly in diabetes. So trying to stay active and to have a positive attitude probably is very important in dealing with this. I think you heard about sleep already, so I won't go too much in depth with that. But again, because this pain from neuropathy is almost always worse at night, sleep disruption is just huge. So you're trying to fall asleep and your feet are burning and stabbing. You can't pull the bed sheets up over your feet because it hurts too much. You've got the restless leg symptoms. And as I said, not sleeping, sleep deprivation makes pain worse. We know that in a lot of different pain states. I do that when I deal with patients with headaches, all kinds of different things. Sometimes just getting 8 hours of good sleep just makes life better, even if you have the pain. So really trying to focus on sleep is very important. And then lastly, unfortunately, we make people worse, we meaning doctors. So again, we like to prescribe drugs. We sort of feel like we're doing something. But very often you have to kind of balance what the benefit is of these drugs. And if you think about it, the best drugs that we have reduce your pain by 50%. So there's no drug that's going to make your pain go away. I mean, I can make your pain go away, but you'd be in a coma, so it wouldn't be very good. But other than that, you've got to accept, okay, I'm going to have a 50% reduction in my pain. So what are the side effects that I'm having from the medications, and are those side effects worth my pain score going from an 8 to a 4, or would I rather cope with it? And so it's important because I do a lot when I see people that come in that have had neuropathy for a long time of just starting to get rid of medicines, because they'll come in on 5 different drugs treating the neuropathy and their pain's still an 8. Well, if that's true, those drugs aren't working, and so why are you taking them? And so rather than adding the 6th drug, we really should get away 1 and then say, okay, it's still an 8, we'll get another one, still an 8, get another one, and just get rid of the drugs. And often people feel so much better when you get rid of the drugs. They're like, oh, well, this isn't so bad. Because again, these drugs have lots of side effects. So the antidepressants affect our thinking, they affect our mood, they cause dizziness, sleepiness with the anticonvulsants, and then the opiates really are a problem. So you not only have addiction and tolerance, but they affect your cognition. Constipation's an enormous problem if you're taking chronic narcotics, and they cause a lot of endocrine side effects, including sort of the sexual side effects. So again, it is our profession's knee-jerk reaction is to prescribe medications, but you always have to ask, was it worth it? Because again, these drugs are not treating the neuropathy, right? They're just treating your symptoms. And so the goal of it is to make your quality of life better. And if we're not making your quality of life better, then you should get off the drug because it's not working. So again, neuropathy causes a lot of different symptoms throughout our body, but having said that, not every symptom is due to neuropathy. So just because you have neuropathy doesn't mean you don't rupture a disc in your back. So if your symptoms suddenly change and they're now worse when walking and radiate down one leg, don't just blame that on your neuropathy. That's probably something different. A lot of these symptoms could be managed and treated even if we can't fix the underlying neuropathy. And so you really do need a good relationship with some physician that is kind of aware of what neuropathy causes so they can say, well, this isn't neuropathy, we should be doing something else. And then just be careful of drugs, because I know we all do too much of that. So I'll stop there and I can take any questions.
Any recommendations or thoughts about diet? What to eat, what not to eat, what to drink, what not to drink?
Well, so diet's a good question. The bottom line is no. That's my short answer. So obviously, in a diabetic, diet is enormously important, right? So we believe that in diabetics, the most important thing is controlling their diabetes. So diet, exercise in diabetics, incredibly important. What I tell people is what you have to keep in mind is even if I don't know what's causing your neuropathy, okay, peripheral nerves are really good at regrowing. So when we talk about central nerves, the nerves of the brain and the spinal cord, when you damage those, they don't come back. They're done. When you damage peripheral nerves, they can regrow, and they're actually very good at regrowing. So what's happening in people with neuropathy is a struggle between the disease, which is killing the nerves back, let's say from your feet up, and your body's attempt to regrow those nerves, okay? So to regrow those nerves, you need as healthy a body as possible. So it will regrow really well in a 25-year-old Olympic athlete and not so good in a 90-year-old, just because there's a difference physiologically. So anything we can do to be healthier probably helps those nerves regrow. Now, do we really know that? No. But it sort of makes sense to me. So a good diet, a balanced diet, again, do we know that huge doses of any of the supplements really help? Probably not. Should you take a multivitamin? Yeah. Do you want to take some alpha-lipoic acid? Why not? So there are those kinds of things that are sort of okay and just sort of fall into that principle of if you're healthy, have a good diet, exercise a bit, you're trying to stimulate those nerves to regrow. And again, we don't have anything that makes the nerves regrow. Even when we treat diseases, immune diseases that cause neuropathy, we're not making the nerves regrow. We're just weakening the disease so your body can regrow the nerves. So just healthy is sort of the bottom line.
Have you seen peripheral neuropathy patients
Yeah, so, well, if there's a treatable cause, so say someone's B12 deficient, or say somebody has another disease that's causing their neuropathy, and you treat the underlying problem, the neuropathy can reverse. In most cases, truthfully, Well, in the immune neuropathy, yeah, they can reverse. So we can see it go away. And sometimes, like in a disease like CIDP, we think now a significant percentage of those patients, the disease may eventually go away after years. So it can happen. The typical kind of neuropathy will be, the vast majority of patients, what we see is it progressing over a few years. And again, the way I think about this is, so to get from my spinal cord to my foot's a 3-foot nerve. And so over a year, 2, 5, that nerve kind of dies back to like mid-shin. And so you're sort of numb to about your mid-shin. And then it kind of stops. It doesn't keep going. Most of them just kind of, okay, I can't keep a 3-foot nerve alive, but I can keep a 2-foot nerve alive. And then you kind of do well like that for the rest of your life. So that's the norm. But certainly some go away, some get better.
My question is about second opinions. With this situation, a lot of folks go for second opinions. The role of the doctor performing a second opinion is, I'm concerned about how he perceives his role. Is it just to verify what the first doctor did and say, okay, yes, I agree or I disagree? Or does he have an obligation to run additional tests to either buttress the initial diagnosis or disprove it?
Well, it's a good question. So I'm not entirely sure I can speak for everyone, every physician, but the way that I would view when I see second, third, or fourth opinions, which I mostly do, my job is to diagnose that patient. And so I actually almost prefer not to look at other records. In other words, I want to take your history. Neurology, particularly neuropathy, is really pattern recognition. In other words, Dr. Katz and I have seen thousands and thousands of neuropathy patients, and I can pretty much make a diagnosis in about 5 minutes just from talking to you. Now, if it's unusual, so if you're the rare case of things, then it's going to require more tests. And do I necessarily believe the other neurologist tests? Again, it depends if it fits in line with what I think, right? So tests, if you think about it, tests are not really designed to diagnose. Tests are really designed to confirm what I think already. So by the time I take your history, even before I've examined you, I pretty much know what you have. And then the exam is just designed to confirm that. And then the EMG just further to confirm that. In fact, there's sort of a debate that we probably do too many EMGs because we already know the answer. So the second opinion really is to give you another idea that somebody else has thought about you from scratch and hasn't missed anything. So that may involve another EMG, it may involve more blood work, it may just be looking at you and going, nope, they're right, that's what you have. And then the question becomes, who do you want to follow with long term? So if you've traveled across the country, that's not going to be your ongoing doctor. If it's another doctor locally who maybe specializes in neuropathy, I tend to think there's some advantage to that, but just depends who you have the best relationship with at that point. It's a good, I don't know is the problem. So, naturopaths, homeopaths, Ayurvedic medicine, for the most part, those forms of medicine are really kind of designed to make your body healthier, right? That's their idea is your body's out of whack and it's damaging your nerves. Actually, I agree with that. In everybody with neuropathy, there's something wrong with your body that's damaging your nerves. Do I think that they really know that, for example, I had a patient who went to see a homeopath and was prescribed sulfur to treat their neuropathy. I don't really believe that's going to work. But if you've got a doctor who, again, is going to work on diet and exercise and lifestyle changes, and then all they're doing really is making your body healthier. And a lot of times, like the homeopath this person went to spent 4 hours with them. I can't spend 4 hours with a patient, it just won't work. But so I think there's some advantage to that as kind of a part of a team effort, but probably not necessarily in terms of having some specific treatment that's different.
I've had an 8 pain, I've had neuropathy for 25, 30 years. Finally found a cocktail of 3 drugs that took my pain to a 0. But one of them is tramadol, which is a narcotic.
Yep.
I know that I'm dependent on it because when I don't take it, I forget I get the symptoms.
No, so, oh, sorry. So the question is, tramadol, or really, I'll generalize that a little bit and just say narcotics. Is there some harm to long-term being on narcotics for 2, 5, 20 years? And the answer is no. So there are a lot of doctors, neurologists especially, that are really kind of reluctant to prescribe narcotics. I prescribe a lot of narcotics. I think if they're regulated, if the patients are reliable, they're an incredible, probably one of the most valuable drugs ever developed by mankind. So in no way, and long term, they're safe. So the difficulty is most people build up tolerance, which is just a natural response to these drugs. So over the years, you might need a little bit more, but again, that's okay. And then just, the concern in some people about addiction and diversion and all the bad things that come from it. But they're very safe long-term medicines. I guess I should stop. Great. Thank you.
Good, thank you very much.